So as we consider whether there's a role for immunotherapy in breast cancer, the question is whether breast cancer is immunogenic, and I, in fact, believe that it is. It's perhaps not as immunogenic as other tumor types, to include melanoma and lung cancer, which are due to mutations which stimulate what's now referred to as neoantigens in an immune response. But we do have evidence that breast tumors are immunogenic in that we express tumor-associated antigens. There are tumor-infiltrating lymphocytes. And I would actually argue that in breast cancer we have one of the initial successes of immunotherapy in trastuzumab, a monoclonal antibody that actually has immune-mediated mechanisms of action. One of the reasons that immune checkpoint blockade works very well in melanoma and lung cancer is because there are a lot of T cells there. And even though I like to say that breast cancer is immunogenic, I acknowledge that it's not that immunogenic. And so if you look at the breast tumors by subtype, about 20% of triple negatives will have immune cells, a little less than 10% of hormone receptor positive. And so I think the real opportunity to make checkpoint blockade work in breast cancer would be to do something to augment that immune response before using checkpoint blockade. And so there's many investigators that are looking at strategies to do just that. One strategy is cryoablation. That's being championed by the folks at Memorial and now Cedars-Sinai. We're very interested at MD Anderson in using radiation as a way to augment immune response. We've been using vaccines. There's forms of chemotherapy that are immunogenic. So I think what we're going to need to do is figure out which of those modalities will cause that immune infiltrate that we can then augment with checkpoint blockade. So our group has been very interested in using vaccines, and what we've learned is that vaccines, if you just give little pieces of the tumor, that probably in and of itself is not going to be effective in stimulating an immune response. You need to give something in addition to that to really jumpstart it, get things going. And so what we've used in our vaccines, and other investigators have as well, it's formally called an immunoadjuvant, but we think of it just as a spark plug to get that immune response going. And in our case, it's been GM-CSF, which we know works by causing the dendritic cells to take up antigen and process it more efficiently. Going forward, for immunotherapy broadly and for immunotherapy very specifically in breast cancer, I anticipate that we're going to need to have combinations. The real challenge in breast cancer is figuring out what those combinations are going to be. We have multiple forms of therapy that are effective, so we have to figure out how immunotherapy will fit within the context of the therapies that we know already work. Work that our group is doing is looking at one of our vaccines in combination with trastuzumab. So that's an example of putting immunotherapy in with something that's already been demonstrated efficacious. And then there are, of course, multiple targeted agents that are becoming more available for our breast cancer patients. CDK4/6 inhibitors, PARP inhibitors for our BRCA mutation carriers. And so to figure out how to combine the immunotherapy with those targeted agents is a real opportunity.